Okay, so let's do the biliary tree. Okay, so basically, you're going to need to know if you know where the organs are, it can help you determine where the pain's going to be. The gallbladder is in the right upper quadrant. It's tucked under the liver here. So when somebody has gallbladder pain due to gallstones or cholecystitis, it's the pain is going to radiate to their right shoulder. Okay, so that's typically something you're going to see in people with cholecystitis after they eat a fatty meal. Okay, the pancreas is kind of in the it's on the left quadrant. The tail is on the left quadrant, and the head is like probably like right here. It's hidden behind the stomach. So when somebody has pancreatitis, that is very bad pain, and it will be typically in the left upper quadrant or mid epigastric area, and it radiates to the back. Okay, and that is very painful. Make sure that you remember the correct way to do an abdominal assessment. You start with inspection, then you're going to auscultate, you're going to percuss, and then palpate. Okay, so remember the phrase, I am perfect path. So inspect, auscultate, percuss, and palpation. This is just a diagram to show you where the gallbladder is. It's not to scale. um, Liver, pancreas, because students get mixed up about which symptoms cause cholecystitis, for example, versus pancreatitis. With cholecystitis, the patient is going to have a fever because they have inflammation of the gallbladder. All right. And they're going to have a high white count. They're going to have nausea and vomiting, and they'll have flatulence. They have all these like GI symptoms after eating a fatty meal. That's like the key. It's going to happen to people that look at these 6Fs: fair, fat, 40, female, family, and they're fertile. Or they could be taking birth control pills like estrogen. All right. So with gallbladder disease or cholecystitis or gallstones, the treatment can be either we do nothing, because people can live with gallstones and not even know they have them. Could be changing the diet to a low-fat diet, low gas producing food. So that's really important for somebody with cholecystitis or somebody that has had a cholecystectomy. So low fat and low gas producing. Medications, something called shock wave therapy. They can have that and surgery. Okay, let's go through cholecystitis again, because cholecystitis is like very prevalent in the United States. So with cholecystitis, this is your gallbladder. When you eat a fatty meal, it contracts and it contains bile. So the bile helps us digest fat. So it squirts out the bile. Now it can get inflamed and the patient can develop cholecystitis. So that could either be acute and chronic, and we are really just going to focus on acute cholecystitis. So most of them are going to have gallstones. So there are some that don't have gallstones, but people who are at risk have maybe are on estrogen replacement therapy or birth control pills. People that are pregnant, and sometimes like people that have had twins will also have gallbladder disease. So who's at risk? Well, people that eat high fat diets, people that are overweight, people that have a sedentary lifestyle, people on like ketone diets, ketotic diets, where they, try to limit their fat, because if you lose too much weight too quickly, it stresses your liver and your gallbladder out. And so they can get it too. But this is really important. The 6Fs: fat, 40, female, fertile, fair, which means white, and family history. So there's a genetic component to it. So those are the people that are most at risk. Diabetics are at risk. Um, so with cholecystitis, They can treat it with diet. Remember I said after the surgery, low-fat diet, avoid gas-producing foods. They can have medications. They can have ESWL to treat it. Now, here is what laparoscopic, the incisions look for laparoscopic cholecystectomy. So they can have laparoscopic cholecystectomy, and when they do it, they put a lot of gas in the abdomen here, okay? And that gas has to come out like after the surgery. So it eventually does, but what happens is this gas is gonna it causes like gas pains in the thorax and the shoulders. So the best thing for the patient is to get up and ambulate, especially like they complain about it in the right shoulder. So they need to get up and ambulate to let that gas move around. That's what's going to help it. So after they have the surgery, you need to introduce fatty foods one at a time. Avoid the gas producing food and beverages. I worked with the surgeon who wouldn't let the patients drink soda after the surgery, and no smoking. Nobody should smoke. So with cholecystitis, I talked about who you're going to have to know, like who's at risk. You're definitely going to have to know that. Okay. You need to know how it presents. So pain in the right upper quadrant, radiation to the shoulder, especially after eating high fat foods. They're going to have a temperature, a high white count. Murphy sign is something the provider does. I wouldn't worry about that. But they'll have like GI signs like nausea and vomiting, eructication, flatulence, anorexia, and feeling full. Now, treatment is cholecystectomy, but also remember they can get, change the diet to low fat so they can try dietary modifications. They can also do that bile dissolving medication or ESWL. So there's a lot of different treatment options, not just surgery with this. So, yeah, the treatment, bile dissolving agents, ESWL, low fat. Now, after an ESWL, watch for signs of dysrhythmias because they can get dysrhythmias, so like palpitations um, after that. So the diet, again, low fat, high fiber, avoid gas producing foods. That's really important. Okay, with hepatitis, what's really important with hepatitis, we're only going to talk about A, B, and C. There's a lot of different types, but this is the most common types in the United States. So you need to know how it's transmitted, what kind of precautions you're going to need, how to prevent it. So hepatitis A is spread through the fecal or oral route, okay, and it happens quickly and it lasts for like 2 to 6 weeks. So sometimes people get this and they think they have the flu. So when people travel, they're going to be prone to this. So um, you need to tell them to drink bottled water, don't eat fresh fruits and vegetables, don't eat raw shellfish to prevent, use good hand washing, practice safe sex. Everybody should be practicing safe sex to prevent hepatitis A, B, or C. Okay. Now, A and B have vaccines, C does not. A and B have immunoglobulin, C does not. But B and C do have medications. So with the assessment findings, what makes it easy is the assessment findings are the same no matter what type of hepatitis it is. All right, so with the assessment findings, the liver is in the right upper quadrant, so they're going to complain of right upper quadrant pain. So they'll have abdominal pain. They will have joint pain, malaise. So it's kind of like getting the flu, right? That's how they feel, and they may get jaundice, and they have nausea and vomiting and itching with their skin. So they're going to need a high calorie, high carbohydrate diet. No alcohol after if they have hepatitis. In fact, some physicians don't let them drink even a year after they get better. And they cannot have sexual intercourse if they have hepatitis until their antibodies are clear, okay, until they clear their antibodies. Now, with hepatitis B, this is spread by blood and body fluids, or booty fluids, I like to say. So, like seminal fluid and vaginal fluid and blood, that can, that's the way it's transmitted, mother to baby as well. All right. So remember, the sexual contact, contaminated needles is another way. Um, not in urine and feces. Okay. So practice safe sex, and they need to be on standard precautions. Okay. Hepatitis B and C, standard precautions. And then hepatitis A, if like they have diarrhea or something and it's messy, you would use contact, but don't really have to worry about that usually. Now with cirrhosis, I'm going to go to this one. With cirrhosis, okay, this is kind of messy, but I'm just going to show you a few things that you really need to know. So with cirrhosis, first of all, let me say this, it's a chronic disease, so it happens over a number of years. Like it could be 30 years before somebody's even diagnosed. Typically, it's found on a normal physical exam, and they notice like the patient has low platelets, and they're like, what's going on? Well, then they figure out because they got, problems with their liver and spleen. So that's how it's usually they figure it out. And by the time, you're going to see somebody in the hospital with this, it's going to be really end stage. So it happens over a number of years. So and this is the stage I'm talking about, okay, because that's what you're going to see mostly in practice. So a lot of things happen. So for example, the liver helps us detoxify, um, metabolites, things that need to be broken down in our body, and one of them is ammonia. And when the liver can no longer do this for you, you're going to get encephalopathy. Okay, so patients with cirrhosis oftentimes have encephalopathy. So they'll have like they'll get very confused early. They'll have a reversal of their sleep wake schedule and an inability to concentrate, and then they can get like something called ataxia, which they get like tremors, and the confusion is really what you have to worry about, because if they get confused, right, they could aspirate, if they become obtunded, okay, so their LOC goes down too. So but the good news is with encephalopathy for liver disease, that we can give them lactulose, okay, and that can bring the ammonia level down so they can get better. So even though they're at the highest stage of encephalopathy, we can give them medication and it will come down. Okay, so high ammonia levels is what causes that. The other thing with cirrhosis end stage is they get ascites. So they get like this big belly right here. Okay, that's ascites, and it can be quite uncomfortable for them, especially like lying in the bed. Right, they need the head of the bed up so that they can breathe. If you've had a baby before, like at the end when you're so big, that's what it's like. They have trouble breathing. Now, what they would do for ascites is a couple of things. They could, for encephalopathy, they would be put on a low protein diet. For ascites, they would be put on a low sodium diet. Obviously, no alcohol, and small frequent meals in liver disease. Now, I talked about earlier that with cirrhosis, it happens over a number of years, and they find it like last minute. They find it when they're doing something else, like they're having a physical, right? So the only way to really diagnose it is to have a liver biopsy. The problem with that is not really a problem, but you have to watch out for it. Is highly vascular, okay? Now they're going to be at risk for bleeding, so make sure you review bleeding precautions because that's definitely a key point, okay? So they're at risk for bleeding. You do a liver biopsy on an organ that is highly vascular. The nursing intervention is to make sure you put them on their right side after the liver biopsy. And the reason you do this is to stop the bleeding, to try to stop the bleeding. I've taken care of somebody who's died after having a liver biopsy, and she had thrombocytopenia to top it off. So she just really wasn't a good candidate to begin with. Now, the other thing that they can have is something called variceal bleeding, which means bleeding from their esophagus. They have like veins in their esophagus that get distended, and they can throw up and bleed, start bleeding out. Okay. So there's two medications that they can have for that. One is called octreotide, and everybody can have octreotide. But the other one is called vasopressin. You cannot give vasopressin to somebody who has got cardiac disease. Okay, that would be a contraindication. So you have to watch out for that as well. But the medications usually work very well. They go to endoscopy and get those varices banded or sclerosed. But anyways, the medication is really important. You can't give vasopressin to anybody that that has cardiac disease. So remember, low sodium diet to help reduce ascites, daily weights definitely. They may put them on diuretics. Paracentesis is the other thing they might have if they're really uncomfortable. They will take fluid out of their abdomen if they need it, and you would just, want to help them get into the position, which is supine. But those are the key points there. Pancreatitis. Okay, pancreatitis happens because the pancreas auto-digests itself. So what do I mean by that? There's a lot of triggers to pancreatitis. The two most common you're going to see are alcohol and biliary obstruction. Okay, so these two things, whichever one it is, triggers the pancreas to release the enzymes that help us digest food early. Okay, so these enzymes then auto digest the pancreas. And can you imagine an enzyme auto digesting your pancreas? That would be really painful, right? So with this, you're going to do a pain assessment. The pain waxes and wanes. It varies greatly depending on the extent of the condition, right? Because I've taken care of patients with pancreatitis that go to the floor. I've taken care of patients that go to the unit because they're so sick. So there's a wide degree of variation in this. But the pain presents with pain in the mid-gastric or left upper quadrant. The pain is sudden and radiates to the back, the left flank, or the left shoulder. It's continuous. I mean, it is really painful. It makes it more painful to lie flat, okay? So it's made worse by laying down. Now, they do like to, they find relief in the fetal position, okay? The knees need to be bent or by sitting up and leaning forward. So remember, the fetal position, that's what you're going to help them with. Okay, this is important, the Gray-Turner sign and the Cullen sign. So Gray-Turner sign is here, this is on the flanks. Cullen sign is around the umbilicus. And if they have these signs, what that indicates is intraperitoneal or retroperitoneal bleeding. And that happens because the pancreas is auto-digesting itself, and it can cause like a hemorrhage. So if they have this sign, that could mean that they're bleeding. Okay, so again, we talked about how to do an abdominal assessment. You're going to inspect, palpate, percuss, and palpate inspect, auscultate, percuss, and palpate last. Okay. Then I don't know if I talked about this with flatus. Okay, so with flatus, if somebody is having either a BM or flatus, that is the gold standard to tell that peristalsis is working or peristalsis has returned. Okay, so that's an important thing to know. With pancreatitis, you also want the diet to be low fat because fatty foods are going to stimulate the pancreas to secrete more enzymes. So that's kind of an important thing to remember. All right, there's one mental health question on the assessment. Now, you guys rocked the mental health proctor, so I think you'll be okay. Fecal occult blood test and stool samples. This is to test for GI bleeding or unexplained diarrhea. Okay, so like maybe you think your patient has C. diff, they may need a stool sample. It's tested for, the all-caught blood, you test the stool for it. You need 3 samples on 3 separate days. You're going to tell the patient to avoid vitamin C rich foods, red meat, poultry, fish for 3 days before the test, okay? Now, these endoscopy tests are really, they're, standard procedures. So colonoscopy is usually for everybody over 50. They get their first one. We worry about older people getting it because they have to take this bowel prep, and the bowel prep basically cleans out the colon, so they're going to have diarrhea. So you worry that they're going to get metabolic acidosis, okay? They'll after the procedure, they are going to have lots of flatulence, lots and lots of flatulence. That is normal. With an EGD and an ERCP, okay, these are tests that where the gag reflex is going to be numbed. They get conscious sedation, so you need to make sure you're checking the gag reflex before you give them anything, after the procedure and before you give them anything to drink. That's the important things for that. And then complications of endoscopy, I talked about aspiration due to the moderate sedation. So make sure with these 2 tests, you're checking the gag reflex. All right, with non-inflammatory bowel disease, again, this is the order that you need to do the abdominal assessment. These are hernias. Now, hernias happen in a lot of different places. They could be incisional, they could be inguinal, femoral, umbilical. If they cannot be moved back into place, we call that irreducible, so incarcerated, okay? They are going to need a surgical evaluation because that could lead to obstruction. All right, this is, and I'm going to talk about obstruction in a little bit because you're going to need to know the signs and symptoms of that. All right. So this is a strangulated hernia right here. So this loop of bowel has, I don't know if this is umbilicus or whatever, but this loop of bowel has slipped out of the peritoneum, and this is going to become necrotic. Okay, that's what we worried about, that it will. Anytime you have like a purplish or a blackish kind of color, you worry it's necrotic. So the findings you're going to see as tachycardia, abdominal distension, fecal smelling, vomiting, and fever. Somebody has an intestinal obstruction. So with intestinal obstruction, you worry about necrosis and perforation or rupture of the bowel. If somebody ruptures their bowel, all that fecal matter is going to go in the abdominal cavity and they can get peritonitis and die. So this is very important that you are able to recognize this early. And I'm going to teach you some of the cardinal signs too, so of intestinal obstruction. So there's 2 types of intestinal obstruction. One is mechanical, so they're going to need surgery. And what I mean about mechanical are all these, strangulated hernias, adhesions, things like that, okay? Non-mechanical obstruction is like a paralytic ileus, so they're not passing flatus. They don't have bowel sounds. What you need to do for them is to encourage them to ambulate to promote flatus, okay? So flatus indicates the return of peristalsis. So that's what you do with them. Now, for somebody that has perhaps a mechanical obstruction, okay, what you're going to hear when you auscultate is high-pitched tinkling sounds above the obstruction in one quadrant and hypoactive bowel sounds below in another quadrant. All right, so a hypoactive bowel sound means you don't hear a sound for 30 seconds, okay? All right, so that's a key point right there. You need to have it, because if you don't act on this right away, okay, you hear these tinkling high pitched sounds and then the hypoactive below, the patient can perforate their bowel. Now, all this gook is going into their peritoneal cavity. They're going to get peritonitis. You need to know the signs and symptoms of peritonitis. Peritonitis is peritonitis no matter how it happens, okay? So that's going to be a high fever, high white count. The patient's going to have abdominal tenderness. They're going to be guarding. They may have nausea and vomiting and bloating, and they may have a board-like abdomen. Okay, so make sure you know those signs and symptoms. And this is the order abdominal assessment again. All right, and then gastritis is inflammation of the stomach lining. This is a different condition. It could be caused by H. pylori. It could be caused by NSAIDs, ETOH, smoking, caffeine. The signs and symptoms are like heartburn, nausea, bloating, black tarry stools, okay? Complication of gastritis, okay? So black tarry stools means bleeding, right? But complication is that they could have a gastric hemorrhage. That's why it needs to be watched. The next condition, constipation. I think you probably had this in fundamentals. Patients are going to need to exercise, increase their fluid, drink water, eat high fiber, and try to go to the bathroom at the same time every day. Medications include yes,
When
yes.
you say the black tarry stools, what is the difference with that as it pertains to the stools when you have pancreatitis?
Pancreatitis will have normal stools. Do you mean like if somebody's obstructed, like they have cirrhosis or pancreatitis and their bile duct is obstructed, they have clay-colored stools?
Yeah, it's like when they're going to the bathroom, it's like their stools aren't as frequent, or it's not. Is it more like a constipation, or is it just where it's just more liquid from the fat or oily type of substance to it?
Okay. You're talking about chronic pancreatitis.
Oh,
For
that's what that is. Okay.
chronic pancreatitis, okay, so what happens with that is the pancreas can no longer release the enzymes, right? So what
Okay.
happens is the patient can't absorb food, so they have steatorrhea. That's fatty stool, and it floats.
Okay.
Yes, very good.
Okay.
But this
Okay.
the black tarry stools means blood is in it.
Oh, okay. Gotcha.
Yeah.
Okay.
So the medications for constipation, you're going to do the bulk forming first, then the stool softeners. If you have to, you'll do stimulants, and enemas are the last resort. And you really don't want to do stimulants if you don't have to, but sometimes you have to. All right, with GI, with the GERD. Okay, so GERD is kind of very similar to peptic ulcer disease and also gastritis, and they're kind of caused by the same thing. So GERD happens because the lower esophageal sphincter, which is right here, and this is a closed one, right? This one is relaxed, so it allows the gastric contents to come up into the esophagus, which doesn't feel good, okay? So kind of things that do lessen it, or kind of the risk factors, I should say, are people that are obese because the pressure makes this sphincter weak. People that smoke, people that drink alcohol or too much caffeine, um, they can get GERD. Okay, so complications. I'm not sure if this is going to be on your proctor. I had a question about it though. They can get what's called a Barrett's esophagus, which can eventually turn into cancer. Okay, so that's the risk there. It's diagnosed by endoscopy, and what they're going to need to do is they'll go on antacids, or an H2 blocker or a PPI. Remember, PPI is given daily, not PRN. All right, they need to stop smoking, stop drinking alcohol. They need to elevate the head of the bed when they're sleeping. Um, so you want to tell them all those things about their diet. They need to be NPO 2 hours before bed. Um, that's going to help them. That will help GERD patients. That will help patients with hiatal hernias. Same nursing diagnoses. A lot of these conditions we're talking about in the GI system, you want to avoid spicy foods, coffee, alcohol, smoking, chocolate, all the good stuff, right? Low fat, high fiber diets. So that's important. Now, also, I mentioned NPO at least 2 hours before bed. Raise the head of the bed 6 to 8 inches. Eat a low fat diet. Don't wear tight clothes. No smoking, no drinking. Now, with peptic ulcer disease, this is caused also by H. pylori bacteria or long use of NSAIDs. And NSAIDs can irritate GERD as well. People that are on long-term corticosteroids, people with a history of gastritis or a family history of it. So what you worry about is bleeding and perforation with these two things. Now, the gastric ulcer is the one when they have pain when the patient eats. Duodenal, they don't have pain till 3 hours later, and it makes sense because if you think about it, the duodenum is further away from the mouth. Okay, so it takes longer to get there for them to have pain. But duodenals are the ones that awake in the night. So you're going to monitor for GI bleeding, which would include the dark tarry stools, okay, bright red blood or coffee ground vomitus, abdominal bloating. Um, Again, their diet's the same. No spicy foods, no alcohol, no caffeine, no smoking, eat low fat, high fiber. So that's important to know. Well, most of these conditions have the same diet. So that makes it nice. So enteral feedings, okay, these can be intermittent or continuous, and you've probably run into this already in fundamentals, but also in clinical. Um, this is a disposable bag. It can only hang for 24 hours. It needs to be changed every 24 hours, I should say. The liquid tube feed that you put inside, you can only put up enough for 4 hours, okay? And this is different than the pre-made feedings that, like Jevity, that have the tubing that comes with it, and it's a closed system, so you can hang this for 24 hours. With an NG tube, okay, so the gold standard for checking where it is an X-ray and check the aspirate for pH. You want a low pH, like 1 to 4. This is a nasogastric tube, and when patients are first getting enteral feedings, this may be the route you have to go. Okay, that's a Salem sub tube. Um, with the complications of the tube feedings include overfeeding. All right, so you're going to check the residual every 4 to 6 hours, possibly hold for a residual about 100 to 200. Okay, so you would hold that and document it. If they get diarrhea, you're going to have to slow the rate and notify the provider. You probably have to send the stool for C. diff and talk with the dietitian. Maybe the formula needs to be changed. Aspiration, I'm sure you know about this, right? This usually happens due to tube displacement. Okay, so head of bed needs to be 30, 1 hour after eating, if they're having like bolus feedings, and then if they're having continuous all the time, you keep the head of bed 30. And if you have to lower the head of the bed, you stop the feeding while you do it. Monitor the temp to make sure they're not getting aspiration pneumonia, and check their lung sounds. All right, TPN. So TPN, so if you have a choice, if the physician has a choice between enteral feeding and parenteral, always choose the gut. You need to use the gut if it's working, because feeding somebody helps prevent ulcers. It helps, it makes them stronger, and there's not as much side effects as TPN associated with it. So TPN is a high sugar concentration, has dextrose greater than 10%. Bacteria love dextrose, so that's going to make them high risk for infection. Okay, so with TPN, you have to have two nurses check it. It's usually hung at the same time every night, like where I've worked before. It's usually 8 o'clock at night is when the TPN gets hung. And you need to check the electrolytes daily. Make sure it's gradually increased and you never abruptly turn it off, okay? Because then your patient's going to get hypoglycemic. So you never speed it up or you never stop it abruptly, okay? It's always, at a constant rate. If you run out of it, you're going to hang D10, and you should have that in the room, bag of D10. You're going to check the glucose every 4 to 6 hours, even in non-diabetic patients, because they're going to have high sugars and they may need regular insulin until their pancreas can catch up and figure out how to make the insulin with all this dextrose. They may need coverage with regular insulin. So you need to change the bag and the tubing every 24 hours. It's given through a central line, so you only use that port for TPN, nothing else. Okay. So your complications include fluid overload, air embolism, and hyperglycemia and infection. All right, with bariatric surgery, okay, there's two types basically, restrictive and malabsorption. So restrictive are all like your lap bands, your lap sleeves. And so what they do, they're restrictive, so they reduce the size of the stomach so your patient can't eat as much. Whereas malabsorption surgeries, they have like rerouted, they've, basically surgically removed part of the stomach and kind of rerouted where it is. Anyways, because part of the stomach is missing, the patient will need iron and B12, calcium for the rest of their life, supplements, okay? Also, with the Roux-en-Y, it's like a bigger surgery, and there's, complications with it. For example, after the surgery, you're going to be looking for an anastomic leak. So that means a leak with the anastomosis that the provider does. So the anastomosis is when they sew two areas of the body together. That's what that is. So this is what you're looking for after, okay? Increasing back and shoulder pain, tachycardia, restlessness, and oliguria. Now, tachycardia is the first sign that your body is under stress. So if your patient has tachycardia, you always need to figure out what is causing the tachycardia, okay? So if you have somebody that has had one of these surgeries and then later on in the evening or so, they have tachycardia and they're restless, you better be thinking they have an anastomic leak because that is deadly. It will kill the patient. Now, you never want to manipulate NG tube that a surgeon placed, okay? Because look, if you see this picture right here, okay, you see the anastomosis right here and here. Now, if you go and manipulate an NG tube and put it down further, right, and you pop one of these, you're going to be in trouble, right? So you never manipulate an NG tube that a surgeon placed. All right. Now, after the surgery, I used to work in a center of excellence for bariatric surgery, and it's amazing the work they do, and it's amazing the results patients have because I've seen patients on lots of medications like for diabetes and hypertension leave the hospital and not need those medications anymore. It's really fabulous. So with when they first start eating and drinking, okay, they can only drink 30 milliliters at a time up to 120 milliliters for the first day. That's not, I'm just trying to point out that it's a small amount of fluid. Okay, that's all I'm trying to put out, spaced out. And then they also have to eat 6 meals daily. Okay. Now with dumping syndrome, this is classic ATI loves dumping syndrome. So the signs and symptoms are tachycardia. Again, the body's under stress, tachycardia. They get dizziness, diaphoretic, and after eating. Okay, so these are the interventions that you need to know because you need to explain to your patient how to prevent this. Okay, withhold peel fluids during the meal. In other words, they have to drink not during mealtime. Okay, they still need to eat 6 small meals, but not drink at that time. All right, so drink fluid between meals and not with meals. It's caused by eating refined sugar, so limit sugar, sweet drinks, also like milk products, like lactose. Okay, this can cause dumping syndrome. They need to eat slowly and chew their food very well. Now, they need to lie down after meals to slow stomach emptying, which is different than GERD, right? It's different. So, because GERD, we tell them to not lie down for 2 hours. These people need to lie down after a meal so that the food doesn't dump, okay? They need to be on a high protein, high fat, low fiber, and low carb diet. Okay, with stomas, okay? So with stomas, the important thing is that you need to know a stoma needs to be shiny, red, wet, or pink, protruding or flush. It can be shaped, there's a lot of different shapes. Round is the perfect, or oval or irregular, okay? Um, as So this is ascending, this is transverse, this is descending, and this is a sigmoid. As where it is, so let me start again. So in this area of the bowel, right, an ileostomy would be right here. Okay, that's the beginning of the bowel. So what happens is the stool is very liquidy, okay, but then as it comes around, it starts getting semi-formed and then it gets solid, okay, because that's been an ATI question before. So anyways, your responsibility after somebody has a new stoma, you want to make sure you're looking at it every shift, but more so right after they have it. So stomas don't have any nerve endings, and for that reason, it can become necrotic, and you wouldn't even know it. Okay, so you want to make sure you're looking at the color. It needs to be pink to red and moist. So you never want to see purple, black, pale, dusky, blue. You don't want to see that. All right. Um, the opening of the appliance, remember in Funds Lab you did this, needs to be 1/16 to 1/8 inch larger than the stoma. All right, so you need to report pale, dark red, purple, brown, black to the surgeon ASAP. All right, inflammatory bowel disease. So Crohn's disease and UC have some similarities, but they also have some differences. Crohn's disease occurs from gum to bum. Okay, so the whole GI system from their mouth to their butt. Okay, so every part of the GI system is affected, so mouth to anus. Autoimmune disease for both of them. Family history in Jewish people are more prone to both of these conditions. Now, with ulcerative colitis, it only affects the large colon. So if they have a colectomy, it cures the disease. Okay. Um, when they have bowel movements for colitis, it's a distinctive smell. It's pain. They'll have pain in the left lower quadrant, bloody stools, anorexia, and weight loss. Whereas in Crohn's disease, if they have surgery, it's temporary relief. I mean, it really doesn't cure it. Okay, so Crohn's can never be cured. So it's pain in the right lower quadrant, usually with cramping, diarrhea, and anorexia. Um, Both of their diets need to be low fiber, high protein, and fluids, and that's important to know. You're going to monitor their weight, their INO, characteristics of their BMs, bowel sounds, and teach them if they're going to have ostomies, teach them how to care for it after surgery. Watch out for GI irritants like NSAIDs, alcohol, etc. Okay, avoid gas forming foods. Um, so yeah, these are prevalent. Um, and usually, like people with Crohn's disease, have to spend some time on TPN as well. Now, with appendicitis, this is an inflamed appendix. Okay, they have pain at McBurney's point, which is right here. It's in between the umbilicus and the iliac crest here. So right here is usually where they have it, in the right lower quadrant. So they could be guarding, they could be in the fetal position, they're going to have fever, increased white count. Now, the reason, especially with young women, that you want to get this taken care of right away is because if the appendix does burst, they can become sterile, and you don't want that to happen to somebody, right? So your complication is peritonitis. Remember the board-like abdomen, high WBC, tenderness with guarding, distension, and tachycardia. Do not ever put a heating pad on the abdomen that you think they have appendicitis, because it may rupture. And what happens when it ruptures, they're going to feel better all of a sudden, which is not a good sign, okay, if they have appendicitis, okay, because that means it ruptured. Diverticulosis and diverticulitis. So diverticulosis can happen as we age. It's outpoaching in the colon, and it occurs when the outpoaching becomes inflamed. And it can become inflamed, like diverticulitis occurs when the outpoachings become inflamed. And that could happen due to something they ate that got caught in there. So they need a diet low fiber, progressing to high fiber, like if they have a flare up. No nuts and seeds. All right, what else do you think you guys need? What else do you have questions about? Nothing about the kidneys? Make sure you know the labs in the oligoric stage of AKI. They're going to be the
I
same in
think we
chronic
should go
kidney
over that,
disease.
Ms. Cohen.
Okay. Okay. So if somebody, let me see this one, it might be better for you. Okay, so with an acute kidney injury, there's rapid loss of kidney function, right? A lot of different ways it can happen. A pre-renal problem, don't like focus too much on this. I'm just going to talk about a few things, but pre-renal problem is usually due to low blood volume, like somebody is bleeding out, somebody has hypotension, shock. Okay, the kidney's not perfused, so the kidney gets injured. Okay, intrarenal, you already know this, the nephrotoxic medications, remember your like myosins, right? Also like your NSAIDs. People with lupus and scleroderma are diabetics, and contrast dye can really damage the kidney. So that we will call that an intrarenal problem. And then post-renal is like your BPH, okay? Remember I told you to do that Quizlet. So the phases of AKI are onset. So this is whatever it is that caused it, and then within 48 hours, they usually get an increase in their BUN and creatinine. Okay, so the oliguric phase, the term oliguria means they voided 400 mLs or less in 24 hours. So basically, they're not really putting out urine. Okay, and then after the oliguric phase, they're going to diurese. And diuresing means the kidneys are healing. Okay, so and then recovery can take up to 1 year. Okay, so with the oliguric phase, okay, that essentially means that the kidneys are not working. And if your kidneys are not working, right, this is what you're going to see. You're going to see the patient's going to have metabolic acidosis, because the kidney is supposed to help us get rid of acid, right? They're going to have fluid overload. You're going to watch for those signs of fluid overload, because if the kidney's not putting out urine, it's staying within the body, okay? And they could get fluid overload. They also could get signs and symptoms of uremia, which I'll talk about. They're going to need a low protein diet to prevent uremia. Okay, so they're going to have, these are what the labs are going to show. They're going to have a high potassium, high phosphorus, and you know phosphorus and calcium live in an inverse relationship. So anytime phosphorus is high, calcium is low. High magnesium, high sodium, low pH. So these are the labs you're going to see. Okay, so those are important. And you would see these kind of conditions in a lot of different diseases, like chronic kidney disease, the oliguric stage of AKI. So with uremia, which is very similar in signs and symptoms to cirrhosis, okay, they're caused by different things, but it's the same signs and symptoms. They can also get confused and have encephalopathy. And usually they put them on a low protein diet for that, just like they would with cirrhosis. Anorexia, nausea, vomiting, diarrhea. But the thing you're going to be most concerned about is the high potassium, because you know that can damage the heart, right? They can have dysrhythmias. So you'll be watching out for that, but also fluid overload. But make sure you know the sign, make sure you know which way the labs are going to go, what you're looking for, these right here. Okay, and don't forget the acidosis. So, and then when they diurese, it means the kidneys are starting to heal. So you need to monitor the potassium, because when anybody diureses, they're losing potassium. Chronic kidney disease has all those signs and symptoms I just talked about. Okay, so here are the signs and symptoms like of the oliguric phase, but also chronic kidney disease, okay? So you see the ones that are in brown, this is due to uremia. So they can get encephalopathy, they can get heart failure, so we worry about that, nausea and vomiting, anemia, bleeding. They're going to be itchy. Okay, so that's important. And but the most important thing is the labs. So the labs are going to be high potassium, high phosphorus, high magnesium, low calcium, low pH, low hematocrit, and then metabolic acidosis. Increased BUN and creatinine, that's important too, and a decreased glomerular filtration rate. They could have a fixed specific gravity, which means it's 1.010. Okay, so that's important. And then with the dialysis, some things are important for you to know, especially this fistula, okay? So you need to know you have to palpate for a thrill, listen for a bruit, okay? That tells you it's patent. No IVs, no blood draws, no tight watches, no sleeves like on this arm, okay? They need range of motion. You're going to be checking for the 6Ps during your neurovascular checks. No sleeping on that side. Make sure it's clean, and they cannot carry heavy objects. So make sure you know all the implications of having an AV fistula. And this is what one would look like. This is a gnarly one. So you check the 5Ps because this right here, see how big this is? This could steal blood away from the hand. So that's why you're going to check the hand and make sure it's okay. Make sure that they, don't have diminished pulses, a cool hand, numbness and tingling, or slow cap refill. And then with peritoneal dialysis, you're worried about the first sign of they can get peritonitis, but the first sign of peritonitis is a cloudy effluent. Okay, so you would watch for those signs and symptoms. And make sure that's going well. So remember, peritonitis is the high fever, the board-like abdomen, tenderness, high white count, and guarding. All right, what else do you guys do? Have you guys studied anything? I know you guys are busy. Okay, kidney stones. Okay, so yes. Who has a question? Nobody? Okay, with kidney stones, these are really painful. So the patient's going to be tachycardic, they'll have hypotension, maybe hypertension, rusty, smoky urine. Okay, so the nursing management, you need to strain the urine if they don't know what is causing the renal calculi, like which kind of stone, so they can determine what kind of stone it is. They can get morphine, ketorolac. They need to drink a lot of fluid to see if they can pass that stone, see if they can flush it out. And then the types of stones, there are a lot of different types of stones, but I want you to concentrate on this calcium oxalate. And the reason is that's what I see most of the questions about on ATI. If they get one, stone, see the stone here? This can cause what is called hydronephrosis. So this is essentially a post-renal AKI. The urine is obstructed and it's going to back into the kidney and they can get an AKI. So that's what you worry about. But the main thing with renal calculi, especially with calcium oxalate, is you have to tell them to avoid all these foods like spinach, black tea, um, chocolate, rhubarb, pecan. So you have to know that. That's important. And they can go for shockwave therapy. And I talked about this in cholecystitis. So you're going to expect flank bruising after and hematuria and monitor for dysrhythmias because this shockwave can interrupt the electricity of the heart. Okay. So strain all urine after to determine if the stone passed. So that's important. And then benign prostatic hyperplasia. Okay, so this happens as men age is what happens. Okay, and it's the result of smooth muscle and epithelial cells just kind of multiply. So it impairs the outflow of urine and it can result in prostatitis. Okay, so the risk factors are male at birth. You have to know all this stuff. Urinary stimulants like alcohol and caffeine. People that are obese, people that live in America and eat the standard diet. If your father had BPH, that's going to make a man more at risk. People with metabolic syndrome, and people with diabetes or heart disease. So your signs and symptoms are fun pissed, okay? So it's not fun, so they're pissed. Because they have frequency, urgency, nocturia, sometimes greater than 4 a night. They have a poor stream and intermittency. So the urine starts and stops, okay? And so they have trouble voiding. The sense of not being able to empty the bladder completely. They're straining, they dribble, and the patient can develop kidney disease if the urine is continuous. With the diagnostic test, they're going to have high white, their urine's going to show white blood cell count, hematuria, and bacteria. The CBC, the WBCs are going to be elevated. BUN, if they're having kidney problem, that'll be elevated. With medication, they can get medications for it, but this is what is highly tested, the transurethral resection of the prostate. So this is a TURP. The surgeon basically goes in through the urethra and it with this surgical tool and rotor-rooters the prostate. Okay? So so what happens is all these little like pieces of the prostate are now like in the bladder and it can clog it up. So what they do is they do what's called a Murphy drip or constant bladder irrigation is the proper term, but we all call it a Murphy drip. And so you have this bottle here. It's usually bags of saline, and they're big bags. They're like 3,000 mLs, and they're hot. They're really heavy, and you have to put them on. And usually you put, oh, here we go. Usually put two on to like the IV pole, right? And you clamp off this one and you use this one, and when this one's done, you clamp off that one, and you give this one, and you get a fresh bag here. So, anyways, What you're trying to do is run a continuous bladder irrigation. You never, ever, ever want to see bright red blood. Okay, so you're making it a nice rosé color, we used to call it. So it's a three-way catheter with a 30 to 45 milliliter balloon tapped tightly to the leg to maintain traction of the surgical site. So you're going to monitor the INO, keep the urine a rosé color, and you do that by adjusting the rate of this constant um, bladder irrigation system. So bladder spasms could mean there's retained pieces of prostate causing obstruction. So what you would do would get one of those big piston syringes and irrigate with 50 mLs. Call the provider if you're unable to dislodge it out, because you can give them an acute kidney injury if you can't get that urine out. So they're also at risk for high risk for DVT. After they DC the three-way catheter, the urine should be amber in 3 days. No heavy lifting and no sex for 2 to 6 weeks, and increased fluids. When men had, like I worked in the PACU, and we would get these a lot, and the men would come out and be like Groundhog Day. They would like crawl out of bed. They would have the sensation they had to pee so bad. They would just try to crawl out of bed, and it was all you can do to try to keep them, calm and in the stretcher. All right, for UTI, lower. Women are at risk. People with diabetes, people with neurogenic bladder, older adults. Um, the symptoms you can remember fun wise, you probably had one before: frequency, urgency, nocturia, nasty smelling urine. Um, the UA is important to know what you're going to see in a UA if somebody has a UTI. So you'll see positive leukocyte esterase, you'll see bacteria, you're going to see white blood cells or pyuria. Nitrate means that it's positive for E. coli, so that you'll see that. They could have red blood cells, and the pH will either be high or low. Okay, so it's not going to be normal. Signs and symptoms in older adults, the first sign you usually see in an older adult is confusion. They may have new incontinence, and you're like, what in the world is happening? Um, they could have nocturia, and then they could also develop urosepsis. So hopefully you're going to catch it like when they become confused first off. Okay, so you can prevent urosepsis. Pregnant clients, if they have a UTI, they got to be treated as soon as possible because it could result in preterm labor. Nobody wants to deal with that. So the antibiotics include the penicillins, sulfa drugs. If anybody gets urticaria, you're going to stop the medication immediately. For quinolones, which is your Cipro, okay, they need to report ankle pain because it could damage the Achilles tendon. They have a sunburn risk, which means they're photophobic. Now, don't get, not photophobic, photosensitive, okay? Photophobic means they don't like to, light hurts their eyes. Photosensitivity means that they're going to be more prone to sunburn. So don't mix that up. Take with a full glass of water. They need to report watery diarrhea. And this pyridine, phenylpyridine, it's going to turn the urine orange, and that's an important nursing implication. It's a urinary analgesic, so your patient should feel better, not have that urgency and the pain of a UTI once they take that. So your client education includes making sure you're telling the patients to empty their bladder every 3 to 4 hours, void before and after sex, drink a lot of water, use cranberry-based products, wipe from front to back, no bubble baths, don't wear underclothes that retain moisture. I said finish antibiotics. That's an important one. Now with an upper UTI, so the difference between an upper UTI and a lower UTI, they have a lot of the same signs and symptoms. Okay, um, all that's happening here is E. coli. It didn't stop at the bladder; it just kept going up and into the kidney. Okay, Usually the young women, 20 years old, are having it because they're not voiding after 6. So it has the same signs and symptoms as a UTI. All right, so dysuria, hematuria, burning, itching, frequency. The symptoms that are different than a UTI is CVA, which stands for costal vertebral tenderness. This distinguishes upper UTI from lower UTI. So your patient may also have nausea and vomiting, chills, fever, sinus tachypnea. In other words, they don't feel good. If they have a low blood pressure, it could mean they're getting septic, okay? So they would just treat this, they need to keep taking their antibiotics till they're done. There is a chronic version. Let's just stick with the acute form because this ends up as chronic kidney disease, and you see all the labs I told you about before. So people should drink 2 liters of fluid a day unless it's contraindicated. They should take acetaminophen for fever and pain, pyridine to as a urinary analgesic, and they'll be on antibiotics for several weeks if they have this. So I think I hit everything. Okay, I kind of went over urinalysis already. If you ever get, you won't, but the creatinine is better than the BUN, and the creatinine clearance is top dog, but you have to do a 24-hour urine. So we usually, check the creatinine to tell if somebody has kidney disease.